the most important development over the past few years for me, when I look back at when I started off and where we are today, and that is the importance of a heart team approach to the care for these patients.
Mm-hmm.
So when I started off, I have to be honest, when I started off, you get a call from a cardiologist that I just capped someone into a cabbage. They're in room 402. Thanks, bye. And you would go see them and tee them up for surgery. And there wasn't much discussion about it, and that's just not a very good way to do things. And looking back, I was like, this wasn't a very, very thorough approach to things. Today, we have a heart team approach where I work very closely with, first of all, other cardiac surgeons. We're not in silos, working totally independently or at worst competing against each other. And we work very closely with interventional cardiologists, general cardiologists, who are part of the evaluation and decision-making process. And then also increasingly, as we work in structural heart realm with aortic and mitral valve disease, and especially now also as TAVR, the catheter-based aortic valve replacements have become very preeminent. We're looking at, we need a cardiac imaging specialist. Mm-hmm. So cardiac imaging informs us tremendously now. So in my practice, I don't really evaluate patients in a solo sort of way. We meet weekly to review just virtually every case. First, certainly difficult cases, but virtually every case to decide mm-hmm. what's the best strategy for dealing with a particular coronary anatomy or a particular valve problem. So yeah, we work as a heart team and determine the best course of evaluation, the best course of treatment, and even our clinic with the TAVR technique, the catheter-based valve implants that are now done. Patients, we have to decide, and patients have to decide. We work together to decide what's the best approach to replacing the aortic valve. Is it surgical aortic valve replacement or catheter-based aortic valve replacement? And so we have a joint valve clinic now. So it's staffed by myself and other cardiac surgeons and interventional cardiologists, and our nurse practitioners, and patients are seen by us simultaneously.
Wow.
And evaluate simultaneously, and then we have shared decision making with the patients.
So it's truly like a multidisciplinary approach now.
Yeah. So
it's pretty cool.
So using aortic valve disease as probably the preeminent example, they get referred to us and they're seen in their clinic by the cardiac surgeon, the interventional cardiologist, and their nurse practitioners, and then whatever workup is done or is recommended, and then the data goes to a valve committee, which comprised of many of us, and the case is reviewed and decision making is decided upon, and then the procedure is done jointly by a cardiac surgeon and an interventional cardiologist. So this is truly, very collaborative, and I've found it to be incredibly beneficial and very gratifying. So, I've learned so much from working, directly with my interventional cardiology colleagues. We're working with imaging specialists, and our understanding of valve disease and the various interventions is so much more detailed and in depth than it ever was. And I really can't imagine practicing it any other way. I think the other benefit to this or aspect of it is that we are all functioning as a heart team, and there's no competitive interest that skews our decision making. Mm-hmm. It really is what's best for the patient, and evidence. We try to be as evidence based as possible, and I think patients really appreciate that when they see their doctors and the nurses working together and coordinating. Mm-hmm. So that's one big change I've seen over the years since I first started out.